Welcome. My name is Susan Goldsmith. I am a geriatric assessor and I work with primary care. So I've met a memorandum of understanding with primary care physicians, the Renfrew Medical Group, the Renfrew Health Village, Kalbogi Medical Center, Dr. Matosh, and also the Madawaska Family Health Team. So right up that Highway 60 corridor. I'm not an expert at functional assessment, I'll tell you that. But in COVID, I've had to do a lot of work over the telephone, and I find it very challenging when you're not in someone's home to do that functional assessment. And I thought that perhaps people that work in hospital, in the emergency room or at the bedside, you're probably facing similar issues, same as me. And so I maybe just thought I'd share my experience and give you a little overview of sort of tips and tricks that I've learned along the way. So these are the goals of my presentation. Why should we assess function? We're going to try to go over the different types, sort of how-to, and I want to focus a little bit on the impact that different things can have on function. So mood, cognition, physical ability all play a different role. You have to be careful about differentiating between each one. Along the way, we'll cover some safety and risk factors that are always pretty important, and just important considerations, consent, judgment, our own personal viewpoints, the importance of collateral history, and then I'll talk about some resources as well. That's what we're going to try to cover today. So I started off with a quote, and I apologize, I didn't put the source in here, but I think instead of a definition, these two quotes really capture for me what function is. So the keywords in the first one, if you look at it backwards, I think you really can understand how someone's support system and their environment can play a big role in how they function, and then that can impact on their health. It's all very much interconnected to me. And you can look at someone in a really rural environment, but they've got a great social support system, lots of family, friends checking in on them, and they're healthy and they function well. But when one of those things falls off, maybe they're living in that same environment, but they have ill health, then their function can really decline. So it's all interconnected. And in the second quote, I think the key word for me, if you read that through, the wish to live autonomously is often something that patients express. And I think sometimes elderly people mix up independent, not accepting help, as living autonomously. But autonomy to me means driving your own bus, being in charge of your decision making. So that's a big distinction for me. And I think that's important to consider. And again, that holistic looking at the environment and your social role as well. So why should we assess function? Well, there's a number of really big, important reasons. For me, I often see this as an indicator of acute illness. In fact, it's become part of our COVID screening, which I find a little bit much to ask a screener to do. They're not going to come into you in the triage and they say, oh, mom is not functioning well. But they might say to you, mom's just not looking after herself in the same way she used to. She just doesn't look like she's taking care of herself as well. And so that's an indicator. And sometimes with the elderly people, you don't have the normal responses to illness. So you're not going to get that big fever response when they have a pneumonia. It may look different. And sometimes the families are picking up on that decline in function before there's actually any real obvious symptoms of illness. Diagnostic criteria for dementia. So dementia, as you recall, is a cognitive decline and a decline in one other domain. So for example, decline in verbal fluency might be a progressive primary aphasia. A decline in behaviors might be a frontotemporal dementia, but typically what we are looking for is a decline in function. So cognition impacting on function would be actually a diagnostic criteria for dementia, typically seen with Alzheimer's and vascular type dementias. When we're not sure if someone is crossing that line into cognitive impact, we might actually send them for a CPT or a cognitive performance test. And that's a test that the occupational therapist will do to determine if, very objectively, if their cognition is impacting on function. They do that with the day hospital. It's part of a capability assessment. So before you can determine if somebody is at risk,
No, it's not
or sorry, if they have a lack of understanding or lack insight, you're really going to know what is their actual risks. And so digging deep into how they're functioning is going to be the baseline about first step at helping you decide if that's going to be helpful or not. The second thing that I think discharge planners see all the time is you really need to know how they're functioning so you can determine what kind of things that you need to put in place so you have a safe, sustainable discharge. So let's just review what types of function you have. Okay, so you might have heard of these before. ADLs, so activities of daily living. You might often see it called BADLs, so basic activities of daily living. IADLs, instrumental activities of daily living, and AADLs may be less familiar to people, but it's advanced activities of daily living. So we're going to go through these in a little more depth. So activities of daily living, I read a great quote and it said, these are things that you do within the first 20 minutes of waking up. And IADLs are what you learn to do after you go off to university or leave your home. So they're things that you have to take over to maintain your household. So activities of daily living, think of what you need to do to look after your own body. That's what we're focusing on with that. Instrumental activities of daily living are things that support your household, the management of your household. They're often more complex and there's sort of a hierarchy. So for example, if you think about the most complex things that we do are, maybe finances, driving, managing medications, then maybe cooking, meal planning, grocery shopping, and then maybe tasks that are simpler, like doing laundry and washing the dishes, are more simple tasks. So when we look at a progressive cognitive decline, often the most complex tasks are the first ones to be lost. So you might see, and even within a task, the more complex pieces, like maybe managing your income tax, is harder than remembering to pay your monthly phone bill. So the more complex a task is, the more it's more likely to be the first one to be lost when you have a progression. Any decline, often, just think acute illness should be the first thing that comes to mind. Take a look at that and rule that out first. When we look at advanced activities of daily living, I always ask people, what do you do to keep yourself entertained? How do you spend your day? And get a sense from them what it is they like to do for socialization, entertainment, and exercise. So things like, and any decline, again, can be an early indicator. People that give up activities can give them up because they become too difficult, like with a cognitive decline, or because they've lost interest, which is a big indicator of depression. And I think these are the questions around this that I kind of try to figure out apathy. So you can see apathy in both of these things. So it's really difficult to differentiate. Questions around this would be like, for example, when you look at the complex activities, somebody that's going out to play bridge in person 3 times a week, and then they've slowly given that up and maybe they're having more difficulty with that. People often tell me, well, I just watch television, but the person that can't tell you what shows they like, are they just sitting there kind of apathetic and not really that interested in what they're watching? Difficulty using the remote control can be an indicator of cognitive decline in this. So this is an important area that don't overlook this when you're asking someone about their function. So we're going to dive a little deeper into ADLs, and I apologize, Jack Nicholson. I always think there's a Canadian element here that we have to take into account, and that's TUCED. You get this person that normally is very well dressed, they're neat and tidy, and they show up at your doctor's office or in Emerge and they've got wild hair and it's -30 out and they've jammed that toque on their head. So we all have it. So when do you know when it's a problem? What do you got to look for? So the areas that we're going to look into are bathing, showering, grooming, personal hygiene, dressing, toileting, feeding, and eating. So when we talk about bathing, if we look at that, one of the things you really have to be conscious of is that this cohort of people, when you look at older people, say over the age of 80 even, they don't typically bath every day. It just wasn't in their culture. It wasn't something that they did. This is something that, I shower every day, right? But sometimes this is not what this generation did. So you just have to be very aware of your own personal values around bathing and try to keep that judgment out of your voice or your out of your affect in all ways, because you are really interested in what they're doing. You're not wanting them to say, oh, I'm having this conversation with this nurse in a hospital that's super clean. I guess the answer must be I bathe every day. You want the real answer. You don't want what they think they should be answering. So that's important. One way to get that is to ask them about their preference. So I always start with something like, what do you like to do? Do you like to have a bath or a shower? Or do you just like to have a little wash up at the sink? What's your preference? And that lets them know that either of those three choices are balanced, and you're not telling them, you're not putting your judgment in there. So you're just asking what their preference is. And then when you want to find out how often they're doing it, I often preface it with a statement like, a lot of people that are older don't like to have a bath every day because it's really drying on their skin. What do you find? How often do you need to have a bath? So I can explore how often it occurs without making them feel like they're being judged. I think that's important. I always have to consider, don't take for granted that they have even access to running water. We have lots of rural environments that, it's just not possible. When I ask about bathing, you need to find out where is the bathroom. Like a lot of people, the blocker for them to get in the tub is the fact that it's downstairs, or they have to go upstairs and the stairs are really steep and narrow, and so it's mobility that's the reason why they're not having a bath. If they're using the tub, ask them to describe how they get in and out of the tub. Is it something, can they sit right at the bottom of the tub? Or sometimes people will say, oh, I've got a bath chair. Okay, well, that's great. How do you find you need to use that bath chair? Just because you have equipment doesn't mean you're actually using that. When you look at a person's physical ability, consider what they came in with. And if they've got balance issues, or if they've got COPD issues where they get short of breath very quickly with any exertion, you're going to ask, you're going to consider that in the back of your mind, that this may be somebody that's standing unsupported, especially while they wash their hair, is something that's going to put them at big risk. So sometimes you want to know as well, do you feel nervous about this, or are you afraid of falling? It just gives you an idea of their insight into what their risks are. I think it's really important to always correlate your observations with your history. So I often go back to like the paramedic report. If they're brought in by an ambulance, that paramedic will often write a note about the condition of what they looked like when they came in, and the emergency nurse sometimes will as well. So you can get that kind of observation about what they were like at home. And you're going to maybe in the course of your investigation looking at a history of rashes, especially in folds, yeast, things like that. When we look at grooming, obviously you've got the person in front of you. You can look at that. I think about the history with grooming, and I just think of this one gentleman I had. He was in the military, clean shaven his entire life. And then probably 2 years prior to his diagnosis of dementia, he started growing a beard. And the family thought that was very strange. So you're seeing this man and he's bearded, and you think, well, that's just what he looks like. But no, that's a very drastic change for this man. So it's important to get that collateral history. When you look at nail care, you can see this yourself, but often foot care is something that's difficult. Dr. Dalziel has always said that if you have difficulty managing your nail care, your toenails, that probably you've got a dementia on board. It's one of those issues that it's an indicator. So, and that's a really good thing to do in the emergency rooms. Can I take a look at your feet? I just want to make sure check your circulation. But while you're there, you're going to check to make sure that that is something they can do. Brushing teeth, regular dental checkups. And I think about this man with dementia I had with, he was a retired businessman, very, appeared very well cared for until I saw his teeth. He smiled and I realized he really wasn't looking after his teeth. So this was a drastic change. Someone that really had cared about his appearance. His daughter was a dental hygienist. It wasn't a lack of access or finances. He just forgot and stopped doing this regular checkups. We talked about shaving a little bit. You'll see a change. People will say, well, men especially will say, well, now that I'm retired, I don't shave as much. And that's kind of maybe a normal change. What you're looking for is a change in their normal level of functioning. Hair care. So with women, people that perhaps always went, you have to be careful about that one because there's lots of women that always went to I never wash my hair. They always go to the hairdresser. And now with COVID, they can't get out. So sometimes that's a change. Some people that they bath in the tub, but they wash their hair under the tap in the sink. So you got to ask a little bit of details, because if someone has a postural blood pressure drop, bending over to wash their hair in the sink may not be the best idea for them. And again, washing your hair while you're standing upright in the shower, but you've got bad balance. Now you've got to let go. That can be a tricky thing to do. And makeup, I think of this one lady I had in Emerge, and she always came up immaculately made up, lots of makeup. And over the years that we got to know this lady, her ability to put on her makeup appropriately really declined. It was an obvious indicator that she was struggling with some cognitive changes. So when we look at dressing, the direct observations that you're going to make about clothing, and you might, when someone's sitting there with a Johnny shirt on, you might again have to go back to that history the paramedics provided. When I see people in the emergency room, they don't always plan when their accidents happen. They come in and they've had a fall. Maybe they're in their work clothing. So the clothing that you see in front of them may not necessarily be their typical everyday thing. Just, I think you need to go back again to the collateral history to find out a little bit more about typically, what kinds of, what do they normally wear? Inappropriate for weather. This can go both ways. So I had a lady who the other day, it was -30. She left her appointment. I watched her walk to her car, short sleeves, no coat. I was like, that's a little odd. And then I also had a gentleman, he was there in the summer and he had on a long sleeve shirt with an underwear shirt, a vest and a jacket. And I thought there's something more to that. So just taking note of that. Often footwear is another indicator, people wearing shoes, but it's quite snowy out. And when I look at ill-fitting clothes, it's often an indicator of weight loss. And sometimes it can be a functional decline that they've lost that ability to recognize that they need new clothes or that they don't fit. So they're not shopping as much. There could be more to that if you see clothes that aren't fitting. Some people don't even have access to laundry facilities. So you need to check that out and, take that under consideration. Someone that says, I don't even get out of my pajamas, I just stay in my pajamas all day, it can be a real indicator of mood, low mood, depression, especially if that's a change. I always ask people things like, is it difficult for you to put on your shirts or getting your jackets on? So someone with shoulder issues, rotator cuff, for example, they might have a hard time doing up a bra or getting on a heavy winter coat. Anyone with rheumatoid arthritis or difficulties with the fingers, they have a hard time with buttons, things like that. Bending over can make it very difficult to put on shoes and socks. So asking some specific questions about, is it difficult? And you might get a lot more information just by asking that simple question. It's important to differentiate to find out do they need any cueing versus hands-on help. And I think people that are starting to need a little bit of cueing, so you might say, well, I find that he doesn't change his shirt very often, so I have to take it away when he has a shower, but then he's able to do it himself, versus someone that can't even button up their shirt. It's an indicator of how severe the functional decline is. Just to let you know as well, The line in the sand between mild dementia and moderate dementia is requiring assistance with ADLs. So that's another diagnostic piece as well. People in end stage dementias, people heading into long-term care can often become resistant to care. And it's often a sign when caregivers are like, I can't do this anymore. And if they don't learn some, gentle persuasive techniques, it can be a cause of conflict as well. So when we look at toileting, it's always helpful to ask. I always find it's helpful to ask a really an easy question. So where is your bathroom? Is it close to your bedroom? So you want to get an indicator of how far that is away. Is it an ensuite? That they have to climb a full set of stairs every time they have to go to the bathroom? That's going to play a big role if we've just started them on a whole bunch of Lasix, right? So you got to take the medication list into account about where the bathroom is. Incontinence products, if you can explore if they're having any incontinence, how do they manage that? And some questions you might ask are, how often do you need to change this? So some women will just say, I just wear a pad just in case, versus someone that is just disclosed to you that they're having incontinence, but they only change it once a day as well. So, and management of that, you might need to get a little bit collateral. Are they disposing of them properly? Balance can play a role when they're trying to stand up and change an incontinence product. Balancing and standing, it can be very challenging. It can be easily a two-person job, right? Where you have they do need assistance with that from the spouse. And that can also be a big issue with caregiver stress. It can be, something that people aren't comfortable doing. Asking about equipment. So, is it difficult for them to get on and off the toilet? Is there anything to hold on to? Do they need one of those raised toilet seats? Do they need the commode style thing at the bedside? Are there bars in place? You want to go back and see if there's any evidence in the record of perhaps UTIs where, maybe not being able to manage incontinence products properly is wearing them too long is causing, rashes or UTI. So, and you're also going to probably, that's another part where you're going to dive in and get your collateral assistance as well. People can be pretty private about that. And sometimes children maybe don't know the full story. So that can be an issue. When we look at eating is actually part of ADLs. So I always ask people about do you have any problems chewing, swallowing? And if it's chewing, focus on like what's going on with your teeth. Have you seen the dentist lately? Are there any sore spots in there? People that have lost a lot of weight often have ill-fitting dentures. So dentures just don't fit anymore, and they can have rubbing spots when they try to eat something. If they are having trouble chewing, what types of foods are difficult for them? It's amazing the people that don't have any dentures, but yet they can practically eat anything. So you got to explore, what are tricky things for you. If they're choking, and the other thing I would say, if they're coughing around mealtime, you want to put into your thought process, is there any aspiration going on? Have they had a history of aspiration pneumonias? Is there any history of the CVA? This may be somebody that needs to go on to have a swallowing study done. So you want to keep that on your thought processor. People with Parkinson's who have tremors, it can be physically difficult for them to actually get food to their mouth. There's specialized spoons that you can get that can eliminate that with an occupational therapist. Vision issues, that's going to be pretty obvious, but plate guards can be used, especially in places like long-term care, so that it's easier for people to eat independently. And under this part, I would ask about, try to explore a little bit about why they're not looking after their dentures, getting that fit change. Is it finances? Because that can play a big role in that as well. So just when we look at some services or resources that are available to support people that you're meeting with problems with ADLs, the big two is the LIN, and that's with actual personal support service worker coming in to give that person a hand with bathing. An occupational therapist can look at a bathroom safety assessment, and they can maybe put things in place that allow that person to take over bathing independent, but in a safe manner. The equipment, the Madawaska Loan Cupboard is a great resource. Sometimes people need a bath chair, bars, and changing over your Your bathroom is often something that is up to you to do after you've had the advice from an occupational therapist. A speech therapist can do a little more in-depth assessment about swallowing studies. I don't know about the Lynn one, but I know our Denise Dominy does those. Public health has a seniors dental program now. Foot care nurses can be helpful if you discover there's issues with toenails. I find my pharmacies, especially Lorraine's pharmacy and Aikenhead's pharmacy, those people that order the products are often very well versed in what's out there. So if someone comes to you and says, you won't wear this because it's not fitting, it's leaking, I'm having issues, often they can come up with a different brand that works better. So they're a great resource. I look at geriatric services. If you're coming up with people that are running into problems with ADLs, often they need a more of an assessment if this hasn't already happened. So if someone's coming to the emerge, you can look for a gem nurse. The geriatric day hospital has an occupational therapist. Certainly geriatric assessment is appropriate. If someone is actually to the point where they're resistant to care, you may be looking for the behavioral support nurse through the geriatric mental health team. And again, the Dementia Society. Very informally, if you have somebody who lives in an apartment or even a retirement home, but I'm thinking of seniors buildings, I've suggested to them that they come up with a tub buddy. So I'm going to go in the bathtub. If I'm not out in an hour, you call me, and they let their neighbor know this. And then the neighbor has the key and can pop over in case there's a problem, if they've had a fall. So it just gives people a little bit of self-confidence. Certainly, Angela Peen has been excellent about helping people navigate all these different services. And, really sometimes long-term care is ultimately where people go when they're having a lot of problems that their caregiver can't manage with the ADLs. So we're going to look at IADLs. So that would include communication issues, meal preparation, shopping, finances, medical administration, and transportation. That's a hot one. So I included these are other areas of assessment because they do come up, not often, but sometimes the person you have in front of them is actually a caregiver. So you don't have to just look at what they're able to look after themselves, but you need to consider what roles do they play in the care of others. So it does come up. Care of pets. So I've got a lady right now with a little bit of a progressive dementia, and she always religiously emptied the cat litter box on a daily basis. And her daughter is noticing that she's forgetting to do that, and it's going several days. So that for me, it's actually an indicator of cognitive decline. So child rearing doesn't often come up in our elderly, but sometimes they are looking after grandchildren. Health management and maintenance. So I always think, again, the complicated to the least complicated. So when you look at management of warfarin and organizing all those lab trips and INRs and making med adjustments, that's much more complicated and can take, a lot more cognitive ability to manage that function. Home establishment, you may have an elderly person that's doing really well with their day-to-day stuff, but when they're faced with deciding to downsize or make a move, that can be very overwhelming. And that's where they may need a little more assistance. And then religious and spiritual activities and expression. So somebody that had some certain practices that they always did, and then it becomes something that becomes difficult for them, it can be an indicator as well. So we're going to start with communication. And there's two things. Oops, sorry. There we go. So the ability to make calls and the ability to receive calls. So you got to take into consideration, can people hear okay? Can they hear, they just stop using the phone because they can't even hear it, or they can't hear somebody when they call? What about their vision? Is it harder for them to, look up numbers or press the buttons? Someone that's depressed might just not be interested in communicating and just stop answering the phone because they have no interest in talking to anyone. And somebody with cognition, you might have that apathy where they think, oh, I should call somebody, and they lack the initiative to take that next step to pick up the phone. I often think about someone as well. Someone with dementia might have trouble learning new technology. So I got mom a cell phone, but she never got onto it. Okay, well, that might be something that's typical with dementia. So I always ask, do you have a landline or do you use a cell phone? If they have a cell phone, I ask a little bit deeper, like, do you text with that? Do you use use it for emails? So do you use it for the calendar function, or is it just strictly a flip phone that you're using just for emergencies? One safety question I ask is, what would you do if you had a medical emergency at your home? And, I'm trying to see if they're going to say, well, I just call 911, or someone might very appropriately say, well, I just press my personal alarm button. Very appropriate. But you're kind of wanting to press them a little bit further. So if they say, well, I would call my daughter, I'd say, well, what if it was your daughter that was having the medical emergency at your house? What would you do then? And someone that's quite, I have no idea. And then if you say, well, what about 911? Oh, right, right. Or if that's still a blank, you might think that that could be a safety issue, that they would have difficulty reaching out, or they might just need that number in, big letters next to their phone, for example. When we look at meal preparation, I start with an open-ended question. So tell me about cooking. How are you doing? And you might get all kinds of answers just with that. I think of one lady I talked to, and she says, I don't cook anymore. And I thought, well, you're not fading away. You're eating something. What do you mean you don't cook? But what she meant by that is she no longer cooked from scratch. She typically just reheated frozen dinners. So in her head, that was not cooking. So you kind of got to meet people where they're at and figure out what it is you mean by that. And again, more complicated to less complicated. The more complicated are going to go first. So I often ask about holiday dinners, cooking for a group. So when was the last time you made Thanksgiving dinner? How did it go? Were they flustered? Did they get everything on the table at the same time? There's a lot of organizational abilities that have to go into a pretty high executive function, right? To cooking for a group. So someone that prepares typically from scratch, and you might see a decline where they start using more frozen meals. To the point, I think back to one gentleman I had, and he always, at lunchtime, he came up, he made a cheese sandwich every day. And then his wife said, well, I don't know what's going on. He'll eat the cheese and he'll eat the bread, but he doesn't make a sandwich anymore. Like, it just became too much. So somebody that's no longer preparing food, they're just going to the fridge and looking for something that looks like food. And so they end up just eating basically ingredients. So the ability to bake can be an indicator with your ladies with cognitive decline. Trying a new recipe. So someone that says, oh yeah, I grab a new recipe out of my magazine every week. I'm not as worried about those people as someone that says, no, I haven't baked in the last 6 months. It's just too hard, And then asking, how does the food turn out? And what you're getting at is, are they missing ingredients? Are they leaving the salt out? Are they leaving out the baking powder? And there used to be a beautiful baker, but now, it's just not turning out the same way. Or are they actually forgetting things? So when we look at safety issues in the kitchen, this is where I think if you're actually in someone's home, it's pretty obvious sometimes when someone's having a functional decline. And, you can do that fridge biopsy, and that can be a problem. People with poor vision, they just don't see the green mold, they're not seeing it. But if it's cognition, I had a lady and she was storing frozen food, like frozen, things that were meant to go in the freezer, but she was accidentally storing them in the fridge. And so they were, going bad. And then she had these random kind of jars of food that she said neighbors would bring over, and she was supposed to feed the raccoons with them, but she was leaving them forever. So it's kind of a strange thing. She had a fridge that looked much like that. So you have to look at the different reasons that people can have trouble with their safety issues. Someone that has a lot of pain, for example, they may have a hard time standing for a long period of time. And so cooking can be impacted by that. That's not so much a safety issue, but your ability to stand, so they can't, you have to sit to do a lot of different things. Someone that is bending over, and putting a big roast in the oven, for example, if they've got postural hypotension, can be a really tricky thing for them to do. Some of the hazards that you might see can be caused by distraction. So people with dementia typically lose their attention, their ability to pay attention. So they can get a little distracted. The phone rings and they forget that they've got something burning. They can show poor judgment. So I think of a lady who used to put things in the microwave with tinfoil, not recognizing that shouldn't go in the microwave anymore. and just letting pots boil over and, leaving things in the oven too long, burning things. I always have to consider, though, what I call the rule of 40. So if someone says, well, yeah, I left the burner on, last week, and you're like, oh, that's a red flag. Uh-oh. But you know what? I did it last week too. And it can happen to anyone. So one episode, if they were 40 years old, would you worry? No. Well, that could be the same with an 80-year-old as well. So you just have to be very cautious. One episode doesn't mean really anything. You just have to look for a pattern or more, actually. I always consider too, like the location of the freezer, the pantry. Is that down in the basement? Is there any way that can be brought up if mobility is an issue? So when we look at things like shopping, lots of people have changed their way they shop because of COVID-19. You can also see changes because it's harder for them to walk around. Like I used to go to No Frills, but now I go to a smaller grocery store. They can't walk as far. So that can really impact somebody's desire to go out shopping. And depression. So they don't want to go out anymore. They've lost interest in doing that. I always ask people, a good question is, do you make out a list yourself? Or do you just kind of go and just grab things as you see them? What's your preference? So someone says, oh yeah, if I didn't make out a list, I would forget. It might be a little red flag to cognitive decline. You might be thinking about that. You might want to ask them, do you ever find when you get back home that you've forgotten items? They were on your list, but you get home and you forget items. And they say, well, yeah, that happens a lot. That might be a concern. You might need to ask collateral history from a child or someone in the home. Are they overbuying items? I think of my grandmother, and her grocery list was bread, milk, bananas. And it was the same every week, whether she needed those things or not. She lost that ability to scan her kitchen and scan her pantry. So overbuying can be an issue as well. Safety concerns. And I think about people that they're having difficulty with making a transaction. So like they're going to the grocery store, and I know my father-in-law, I swear the people at the grocery store, they knew what his PIN was because he would say it out loud. And he was very financially vulnerable because of that. But the TAP system certainly makes life easier for them. But so people with cognitive decline can be a little more financially vulnerable when they're making those transactions. You got to ask about food insecurity. A lot of seniors, this is a big issue, and they don't maybe disclose that unless you dig a little deeper. Do you have enough money to buy all the food that you need? And that can be an indicator. You can own your own home, but if you live there by yourself and you're trying to pay for, the rising costs of everything, it doesn't leave sometimes a lot of money at the end of the month. So that can be an issue for people that you wouldn't expect it to be an issue for. Household management. So a good place to start is, does anyone help you? Does anyone come into your home to give you a hand? And it's very difficult to get a sense of how this is going. Obviously, when someone's in a stretcher in front of you, or if you're at the other end of the phone, and that's where collateral is helpful. Have you noticed any changes in your parents' ability to look after their home? What does their place look like? A lot of people are able to do those daily chores, sweeping, doing the dishes. They can maintain those. The more difficult issues when there's physical impairments are those things like, taking care of the lawn, doing the snow removal, doing the dump runs. Where you can look for cognitive decline is, what about sorting out the recycling? Sometimes people, I've heard that spouses have to sort of step in to take over that. Sorting is difficult for someone as they decline cognitively, and forgetting what days the garbage comes at. If they've lost their driving license, these can be big issues that you have to work on. It can be, they need to find someone now to help them with these things. So it can be a big issue if they live in the country and they're used to going out every Saturday to get rid of their garbage. They don't have garbage pickup. I always ask our rural people, how do you heat your home? And that can be a really big, tricky functional issue with people. if they've lost that physical ability to manage wood. And it's interesting though, men sometimes you'll ask someone, well, they don't, if they're in traditional roles and, the men, they don't know a thing about how to run the inside of the house, but they can tell you how many cords of wood they cut, how many cords of wood they have on hand, how many they've already burnt. And you're like, okay, I think you're doing okay, right? Is it their sole source of heat? That's another question, because sometimes if they have a backup, they don't have to use the wood stove. Laundry, I always ask ladies, especially in the summer, if they have mobility issues about clotheslines. You're worried about where the laundry is it downstairs in the basement? You think about someone with poor balance. When you've got something in your arms, you don't have that ability to hold on to a railing. So you've really got to consider where that laundry is. And ladies have pretty inventive ways. I kicked all the clothes down to the bottom and then I move it up one step at a time. You got to get that kind of detail to get an idea of how things are going for them. The one cognitive impairment I've seen with putting dishes away and putting clothing away correctly. I have one gentleman, as I've seen him, he would have a hard time remembering where the weird things went, like the fancy serving dishes and, maybe the ladle that they don't use very often. But now as time goes on, now he's forgetting where the bowls go, like the daily stuff. So that can be an indicator of where someone's at with their decline. So physical impairment, someone that has back pain is often going to have trouble vacuuming. You might ask them about that. Anyone that has trouble with dizziness, lightheadedness, or shoulder rotator cuff things, they're going to have a hard time changing the linens on the sheet. So you might ask them about that if these tasks are difficult. Finances can be a kind of a tricky thing. I don't ask this question early on because you want to develop a trust relationship with that person. This can come across as really super nosy if they're suspicious about what you're doing. Why are you asking these questions? But I just ask them, like, how do you pay your bills? A lot of people will tell you these days they've got automatic withdrawal. And I think the next level question for that would be, well, how long have you had that set up and why did you set that up? So they just set it up recently because they were forgetting to pay their bills, can be an indicator of cognitive decline, or no, I've had it done for years and it's just more convenient. That shows actually some really good insight. Someone that's still paying their bills online or by phone, that can be a really positive sign. Somebody that's maybe not getting out of the bank as often because they've always done it in person, but now because of COVID, they're afraid to go to the bank. So they're not getting things done maybe as quickly as they used to. So when I look at cognitive decline as well, often it's episodic things that are more difficult to remember. So I remember to pay my phone bill because it comes in every month and it's part of my routine. But the things that are sort of out of my routine, like the quarterly water bill or the quarterly taxes or the yearly income tax, those things are sometimes harder to remember. And those are the first things that you'll be asking about. You always have to ask, not only did they forget to pay a bill, but have they accidentally double paid a bill? And I had a lady recently, the propane bill, when it came in, it was automatically paid, but it appeared when she got the receipt, she thought it was a bill and she would try to go in and pay it again, even though it came out automatically. So understanding what this mail is. Sometimes people that are depressed, they stop opening mail, and you certainly can see that in cognitive impairment as well. I always ask, do you have any trouble remembering your PIN number? And some people with frontal dementias, they'll be like, oh yeah, it's 1, 2, 3, 4, 5. And it's like, no, don't tell me, just, are you having any trouble remembering? And certainly, I think every geriatric assessor would be like, the darn tap, because now it's so much easier. People just tap and they don't have to worry about remembering that PIN. I always think about traditional roles as well, and that goes for every aspect of IADLs. But if you were the accountant and that was your profession, probably you're the one that managed all of the finances. So that can mean that one person has never ever they've never handled the money. But and that can be a little trickier to dig at. But often, say for example, if the wife handled all the financial bills and everything, The gentleman is maybe still, going to the hardware store. He's still buying gas. So you can ask about those things that traditionally he has always where he's always made his purchases. So vision can make it obviously can make it more difficult for them just to see to write a check or, to use the bank machine. Mobility makes it more difficult for them to physically get into the bank. I always ask the question, does anyone help you with your banking? Because sometimes that person that's helping them is the neighbor, and that may or may not be a good thing. So then your next question would be, is there anyone in your life that have you assigned power of attorney, someone to actually officially help you with your finances? So that would be another good question to figure out as well. So medication administration, and you could spend a lot of time on this, but basically a good opening question is, what's your system for managing your medications? And just sit back and listen and see what you get, because you might get, well, I just pop the bottles and I turn them upside down, very complicated regimes. Some people pre-pour their own dosettes, or their spouse helps them out with that. And, it's always great to take a look at that to say, does it follow along? Does it make sense with what they've said they're doing? And the same with the blister packing as well. There's different types of blister packing, and some systems may be easier for other people. I would say traditional roles and values and beliefs play a big role in this. So if you've never cared about your pills, it's not your bag, well, you're probably not going to start now. I'd say the pharmacist is such a valuable resource. So if you say, look, he's come in, he's got half a bottle of this left. Tell me, how often is he filling it? Is he looking for it too early, or is he ignored this medication? I had one lady that I went to visit her, and she just forgot she was on insulin, which was kind of a biggie. But things like puffers often go by the wayside, out of sight, out of mind. You're really looking at the organization of the medication. So are they getting the refills on time? Are they able to pick up that medication? So it's more about that, because I'm going to tell you, forgetting to take a pill, think of the rule of 40. It's a memory issue. It's not an issue of function. Difficulty swallowing a pill is actually ADL, and that's the same with being able to physically, squirt a puffer. That's more of an ADL. You really have to look at the risk. Is this a vitamin D that they're forgetting to take, or is this a warfarin that they're at risk of overtaking? That's a really serious one, right? So you got to look at the risk of the medication. I always ask about, tell me how you take your nitro. What's your understanding? What would you do if you ever had a low blood sugar? And tell me how you take your Tylenol. You want to ask about off-label usage. I'm thinking about Gravol and things like that. You need to also understand that people could be quite purposely overtaking medication. It might not be a cognitive issue at all. And you have to think about addictions as well. So transportation, and we could spend probably a whole day just talking about this. I want you to remember that if you have a family that is concerned about driving, there is probably a driving concern. So family are more likely to downplay an issue than they are to bring an issue forward. So if you have 2 or more issues with IADLs, that's an indicator because of cognition. I should clarify that. Then there's likely an issue with driving, and you need to do further assessment probably. That would be a great geriatric assessment referral. So some resources, some of these are well known to us. Match, assisted living. You can look at older adult protection just for a consult. Your pharmacist is an amazing resource. I mentioned geriatric assessment. Personal alarms are great. And often this is going to come down to private pay and informal housekeeper. You're going to notice the LHIN is not on this list. And that is because they really aren't the people that are looking after IADLs. You're going to have to find something else. So I'm not going to talk about this a lot. There are lots of tools out there to measure function. You can grab them. They're a great guideline to use. I even think the CATS Index of Independence is one that's in EPIC, I think. There's a great mnemonic that covers everything, but I'll let you explore that on your own. We're going to briefly, I think we've got time to do a brief case study. So this gentleman, Mr. Smith, arrives in your emergency department, and he arrives, he's very disorientated, can't remember really what happened, he doesn't know what date it is, he's sort of in his dressing gown and his slippers, and his neighbor found him outside. And so his daughter, who comes to see him, she's going to whip over to the house, excuse me, to pick up his clothing so he can at least get home. And when she's there, she becomes quite concerned because it really looks like he's been letting dishes piled up. There's no milk, there's no bread, laundry is not all over the place and in quite a disarray. So whatever are red flags? So first of all, he's, unkempt, unshaven. It looks like he's not managing his daily tasks, shopping, and he's obviously at a falls risk. So the other concerns you're gonna think of, he is still driving. He has a license, and the ultimate one is he safe to go home? So in the meantime, we've done a little bit more work in our emerge, and we've discovered that he's got a pneumonia on x-ray. He's dry. So we're going to do our best to correct that. And the daughter's come back and she's provided us with more collateral. And 3 weeks ago, she was there to visit, and he was the one that made supper for them. He was mobile, he was well, the house was neat and tidy, he was doing well. So now you're kind of questioning what's going on with his judgment. Why didn't he call when he got sick? What's going on? Because it really looks like he was well, he has an acute illness, and now he's had an acute decline in his function. So what are we going to do? Well, we've got a plan. The daughter is going to get the antibiotics, get groceries. She's going to stay with him, lots of TLC. And then when she has to go, she's going to get this neighbor to check in. I mean, this is like a fairy tale because we often don't have this kind of support from family, and then you've got a whole other ball of wax. And she's going to make sure that she stays involved with the primary care provider and attend that appointment with Mr. Smith to make sure there's a follow-up. So the emergencies roles, clear goals of when to return to the emerge. When you are more short of breath, if your antibiotics, you're not better after you've completed X number of days, clear indicators about when to come back. And you're not probably going to do a letter to the Ministry of Transport to say you can't drive. You're just going to ask him not to drive until he feels better. And I would really recommend a GEM referral to assess for any urgent needs, going home program, frozen dinners, maybe CPRU. She's going to be in a good position to check what's needed urgently and also to screen for geriatric issues. Were there previous falls? Is this judgment issue that we saw, is there anything more to that? Is that the beginning of a cognitive decline, or is that just kind of a blip in things? So, and she'll be able to make further referrals if she finds other issues going on. So obviously, if you don't have this magical daughter, you're going to probably need to consider something different. And it might even mean that you're going to need to advocate for this person's admission, because if he doesn't take his pills and goes home and he doesn't eat or drink, he's just going to continue to go downhill. And it's a big safety risk if you don't have that safety net under him, right? Okay, so just some key points I wanted to highlight. I think when you're doing a capability assessment, when you're doing a functional assessment to make a diagnosis of dementia, collateral history is absolutely valuable. You have to still obtain someone's consent. So I just say something like, it's really important for me to get a really good handle on how things were going for you at home. Is it okay if I speak to, your daughter or whoever? Anyone that's in the home and sees what's going on is the best person. Sometimes that's not the family. If a daughter lives out in BC and hasn't visited in several months, maybe it is the neighbor that is going to have the most accurate and up-to-date observations. So you just have to find out who is that person with feet on the ground. And that's where the paramedic who went to pick the person up when they had that issue, sometimes I'll call them and I'll say, listen, you were there. What's going on? After I've obtained consent, of course. Sometimes this is hard, but you've got to always really be non-judgmental. Sometimes patients that come in And you think, well, why isn't their daughter helping them? Good Lord. But maybe the daughter has been trying for years and years and years, and this person has been resistant, and she's been there, and there could be relationships that were impaired years ago. You have no idea what her issues are, what their relationship is like. So you're just trying to gather the information in the most non-judgmental way that you can. You really have to, and that's where your own values come into play, and really recognizing real safety issues other than just, well, that person lives alone, they must be lonely. Well, maybe they're not lonely. Maybe they're quite happy to be on their own. But if there is a safety issue with living on their own, you need to be able to pick the difference and take your values out of that equation. Whenever you're meeting someone that has any confusion, cognition issues, always assume delirium and start from that point first. Rule that out before you even consider a dementia diagnosis. And you have to get collateral in order to do that. You have to talk to someone and find out, when did this start? And, has it deteriorated? When did this change? And don't forget that delirium on top of dementia is super common. If you've got a frail brain, any sort of illness can push you over into a worsening type of confusion. And when you're doing that capability and you're trying to determine if they have insight, the first thing you need to do is make sure they've been educated. So that person that's perhaps made a mistake with overtaking their warfarin, if they've never had that really clear education about the dangers of warfarin and the side effects and what they can run into, they really can't judge the risk and the consequence of taking that. And I think about diabetics. Maybe they are educated, maybe they lack the education. They were diagnosed when they were diet controlled, and now it's progressed, and now they're on insulin, but they never really had that good consult with the dementia educator. So make sure that happens before you try to do an evaluation of someone's insight or capability. So those are just some of the key things that I would consider as well when I'm doing this functional assessment. We got a little bit more time for questions. Is there any burning questions out there? We kind of whizzed through pretty quick.
I just have one, Sue, about the AADLs.
Yeah.
Do you find, I know when I'm chatting with diabetic people, it's tricky right now, or at least for the past 2 years, there's a lot of fear about going out and spending time with people, even within their long-standing friend circle. Do you find that there's tips to go around this? Because it's just the past 2 years has been so out of the norm for everybody that these vulnerable people are really hard to assess.
Oh, this has been, super challenging. I've run into well-meaning family members that have kept their older adults, parents, virtual prisoners. They've not allowed them to even go grocery shopping. And, I think we've figured out how to navigate grocery shopping in a safe way. And so sometimes I've had to really I'm going to say not educate, but just review sort of what we know about COVID, so that, for example, I think there's a way that you can safely navigate this, and starting to encourage patients to come back to, you actually need to go in physically to see your family doctor instead of just having a virtual appointment. So there's times when you need to push people a little bit to re-engage in person and in a safe manner, of course. And then with that loss of activities, sometimes you really have to push them a little bit to look for replacements, so that informal, why don't picking up the phone and talking to your friends more often, or encouraging family to, everyone's going to take a turn calling mom and checking in, engaging new technologies like grandma's going to learn how to do a Zoom, that kind of thing. So I don't know if that answered your question or not, but and I think Seniors Without Walls, there's some new things that have come along where there's some possibilities and options for that person that still feels vulnerable and is staying home. You got to work to bring some social engagement to them. But then there are some people that are maybe at risk, but there's safe ways to navigate the outside world. And I think just gently exploring that with the family so that you can find ways that, you know, with masking and social distancing, is there a way that we can let this person get back to grocery shopping again? Because there's so many benefits to being out and about, right?